Okay guys, good luck ya.
Okay, bos.
Thank you. Cuba cakap Cuba cakap.
Hello? Amali. Hello?
Cakap.
Dengar tak?
Cakap.
Aku nak test screen aku jap.
Okay. Jap. Share lah. Boleh lah. Who can share all panelists? Boleh?
Hafiz nampak je.
Kau dengar tak?
Dengar. Loud and clear.
Boleh dengar clear?
Dengar Alhamdulillah.
Alhamdulillah.
Okay.
Good. Pukul 9 kan? Sekejap lagi aku ambil air jap.
Tadi suara dengar elok tak sekat-sekat
Elok.
Tadi lah aku dah record dah siap-siap.
Lain macam nak rekod.
Malu dah nak speaking dekat Honda ni, ramai-ramai orang.
Oh.
Kain plekat je bro.
Kentul pula. Assalamualaikum warahmatullahi. Clear kan suaraku?
Ya.
Poll ni tak boleh buat poll baru tu. Shoot lah. Macam mana nak buat poll baru tu? Soalan macam mana soalan? Ilani Ramlah ada bagi budak pagi ke pagi?
Dekat grup.
Kat grup. Kat grup.
Soalan sama je kan?
Tengok ni WhatsApp. Tengok WhatsApp.
Oh. Oh, okay. Oh, dah live lah.
Ya. Boleh. Aha. Boleh. Aha. 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 Okey. Nanti tak apalah sebab saya baru buat hari tu. Masa tukar. Okey. Buat yang okey, terima kasih.
Uh, 4 minit lagi. 4 minit.
Bismillahirrahmanirrahim.
Tes. Bismillahirrahmanirrahim. Okay. Okay. Kita boleh start juga sekarang. Assalamualaikum warahmatullahi wabarakatuh. Let's open this webinar with Ummul Kitab. Al-Fatihah.
Alhamdulillah. Ar-Rahmanir-Rahim. Maliki yaumiddin. إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم.
Assalamualaikum warahmatullahi wabarakatuh. Welcome everyone. Thank you for joining us for today's webinar. My name is Dr. Hambali Haironi and I'm the medical officer working here at the Medical Emergency Department at SASMED at IIUM. Today we are going to present trauma update in ATLS 10 edition. So before we start, first of all, I want to introduce our first panelist, Dr. Abdul Hafiz. He is currently working at emergency department with 7 years fields experience. And inshallah this year he will further his study in Master of Medicine. So second and third panelist is Dr. Ramlah Muhammad Ibrahim and Dr. Amira Eliani. They are also working here at emergency department with wide experience dealing with trauma cases. And not to forget our supervisor, our caring head of department, Dr. Shafwan Adnan, and our beloved specialist, Dr. Aida Sharini. Thank you for supervising our webinar today. So our topic today will touch about current ATLS 10 edition update. So bear in our mind, this is only an update on ATLS 10 edition. This is not ATLS course. So this update was released at the end of 2018. Many doctors, medical assistant, nurse will encounter trauma cases during their working hours. Either they are working in emergency and trauma department in tertiary or district hospital. The severity of the case can be life-threatening at the time. So today, airway, circulation, chest injury, and head injury are the main focus on this webinar that will be discussed today. So before we start, just a little housekeeping before we get started. If you had any question during our webinar, please hold them into the end of our webinar as we have time for Q&A session at the end of our webinar. So now without further ado, we will turn this mic to Dr. Hafiz as our panelist and we will talk about a little bit about airway. Please, Dr. Hafiz. Sorry, Dr. Hafiz, your sound's not really clear.
First of all, thank you, Dr. Hambali, for the
Okay.
introduction. Before we begin, let me share with you on how the ATLS started. In 1976, one orthopedic surgeon, Dr. James K. Steiner, piloting an aircraft with his family. Unfortunately, the plane crashed into a field of rural area in Nebraska. Following the plane crash, he himself sustained serious injuries. 3 of his children sustained physical injuries and 1 of his child sustained minor injuries. Sadly, his wife died instantly in the crash. The family was brought to the nearest district hospital. However, he felt that the emergency care provided to his family was inadequate, inappropriate, and substandard. At that point of time, he stated, when I can provide better care in the field with limited resource than what my children and I receive at the primary care facilities, there is something wrong with the system and the system has to be changed. That idea has led to development of a program which gives a better way on how to manage the trauma patient. And that program is called ATLS, Advanced Trauma Life Support. The ATLS program was first introduced in 1980 and this is the relevant ATLS instructor. This program is
Sorry, Dr. Hafiz. Sorry, Dr. Hafiz, to interrupt you. I think your mic a little ada masalah kot mic tu.
responsible communities keep updating this program
Okay.
on latest literature. The latest edition, which is 10th edition, was released at the end of 2018. For those who's not yet seen this book, this is the front cover of the latest ATLS 10th edition manual PDF. So, we are here today present and highlight on this latest edition. Let's get started. This ATLS book comprised of 13 chapters that covers from the initial preparation of the team, initial assessment of the trauma patient, trauma protocol until some specific condition such as burn, chemical injuries, and specific age population involved in trauma until the transfer of the patient. We may not have enough time to cover all the 13 chapters, but we will definitely highlighting the important points. There is no major changes in this chapter 1 initial assessment. In this chapter, we will still following the traditional ABCDE approach to the assessment of trauma patient. We still prioritizing the rapid assessment and treatment of life-threatening injuries involving airway first, then proceed with bleeding before the circulatory issues and so on. ATLS now recommend that only 1 liter of crystalloid is given during the first initial field presentation. And I believe Dr. Ramla will have more to say during her presentation on shock and circulation issues. For pediatric patients which weight below than 40 kg, 20 cc per kg of crystalloid is. And if the patient that do not respond to the crystalloid, early usage of blood products is initiated. Please keep in mind, in this chapter 1 and throughout the other chapter in this current edition, there is an increased focus on team approach and the importance of team trauma. They are emphasizing on the teamwork, signing the team leader who will be in charge of the airway, in charge of the bleeding, circulation, blood product, medication, and so on. And the fact that resuscitation is occurring simultaneously with the primary survey is highlighted. Now, we have come to the chapter 2. The earliest priorities in managing the injured patient are to ensure an intact airway and recognize a compromised airway. In this chapter 2, there is no significant changes from previous ATLS version. The nature and methodology of the rapid assessment of the airway remain unchanged. However, the terminology of RSI or rapid sequence intubation is now being replaced to a broader terminology which is DAI or drug assisted intubation. Not all intubation process requiring muscle relaxant. If induction agent with muscle relaxant is used, it is called RSI, rapid sequence intubation. If only induction agent or sedation agent is used, it is called sedation facilitated endotracheal intubation. But both is considered as DAI, drug assisted intubation. Over the years, alternative intubation devices have been developed to integrate video and optic imaging technique. In this chapter, the usefulness of video laryngoscope is being highlighted for its benefit, especially in difficult intubation, and it may benefit the trauma patient. I think that's all for now. I pass back this mic to Dr. Hambali.
Oh, so that's how the ATLS started, yeah, by the orthopedic surgeon. So, and also RSI currently being changed to DAI in this current update. Thank you, Dr. Hafiz, for brief explanation regarding airway. So before I forgot, this webinar also live at YouTube in channel Tok 1Z. Okay, if anyone kind of apa tak boleh join the Zoom, can open the channel Tok 1Z. Okay, so it seems Dr. Ramlah cannot wait any longer to start her part in this webinar. So I would like to invite Dr. Ramlah to talk about update in circulation. Please, Dr. Ramlah.
Assalamualaikum warahmatullahi taala wabarakatuh, and a very good morning to the respectable EPs, Dr. Shafwan and Dr. Aida, host for today's webinar, Dr. Hambali, fellow panelists, think tank, and then IIUM ETD staff. Okay. Basically, what I'm going to talk today are regarding the ATLS 10 update, that mostly related to circulation. When we talk about circulation, main subtopic under circulation is
Sorry,
shock.
sorry Dr. Ramlah, minta maaf Dr. Ramlah and all panelists boleh off mask tak? Kita rasanya tak perlu pakai mask kot. Okay, minta maaf untuk Hafiz tak apa kot dekat public area, right?
Okay. Main subtopic under circulation that I want to highlight about today is regarding shock. As we know, shock is defined as a failure of circulatory system. Okay. What happened is when there is a failure of circulatory system to provide adequate organ perfusion to meet the oxygen demand of the cellular metabolism, we call this condition as shock. And in trauma, shock is mostly due to hemorrhage. Accountable around 40% of death is due to shock due to hemorrhage in trauma. Okay. For us, the ETD personnel, recognizing shock is one of the greatest challenge in managing the injured patient. During the early management of injured patient, shock is identified by evidence of end organ hypoperfusion present on the physical examination, such as we look at the BP, the heart rate, the pulse pressure, the respiratory rate, the urine output of the patient, as well as GCS. The table relating the physiologic variable with hemorrhage severity has been a part of several ATLS previously. But nowadays, the new addition of ATLF has new two-column parameters, which is first is the base deficit. As some literature recently has challenged the accuracy of classification of hemorrhage solely attributable to the clinical finding itself. As base deficit is easily available in many settings, it can help to decrease the variability of the physiologic aspect. That's why base deficit is now included as part of classification for the hemorrhagic shock. Base deficit have been frequently used to determine the endpoint of resuscitation and have been a predictive for both morbidity and mortality. As early as 1988, David and colleagues have demonstrated the correlation between the increasing base deficit and the ongoing hemorrhage. Since that time, multiple studies have showed a relationship between worsening base deficit and its negative outcome. It includes the increased transfusion requirement, multiple organ failure, acute respiratory distress syndrome, and mortality. So what does base deficit in trauma indicate? In trauma patient, the base deficit show tissue injury severity because it is correlated with lactate concentration. Elevate base deficit and lactate concentration of the shock are related to the oxygen transport imbalance that happen in the cellular level. As we can see from this particular tables, which is a new classification for hemorrhagic shock, deficit in base deficit aspect, class 1, it indicates from 0 to -2 or -2 base deficit. Meanwhile, class 2 is from -2 to -6. Class 3 is between -6 to -10, and class 4 is between -10 to or lesser than that. And if you can see from this particular table itself, there's another column, which is the need of blood. Okay. In patient in trauma, there's a small subset of patient with shock will require transfusion and sometimes may require massive transfusion, as we can see from class 4 types of hemorrhagic shock. Okay. Most often, what does massive transfusion define? It defined as more than 10 units of packed red blood cell that needed to resuscitate a patient in first 24 hours of admission or more than 4 units in 1 hour. Early administration of packed red cell plasma platelet in a balanced ratio, which is 1 to 1 to 1, can minimize excessive crystalloid administration and may improve the patient survival. MTP, or also known as Massive Transfusion Protocol, that include immediate availability of blood component should be in place. And usually in a tertiary or secondary center, we do have MTP protocol that is specific for that particular center. This is to provide optimal resuscitation for this patient because extensive resources are required to obtain this large quantity of blood in short duration of time. Appropriate administration of blood product had been shown to improve outcome in this patient population. And identifying the small subset of patient can benefit us. However, it can be some challenge to identify them. There are few scores that have been developed for clinicians to make a decision regarding how to initiate MTP. One of the scores is what I'm showing you guys now from the slide, is regarding the ABC scores. So ABC scores predict the need of massive transfusion in trauma. So scores less than 2 suggest unlikely need for massive transfusion, meanwhile scores more than 2 suggest there is need of massive transfusion. There are 4 parameters that we look at this particular scores, which is the systolic blood pressure, less or equal to 90, heart rate more or equal to 120, a positive fast scan, and any penetrating torso injury. Another scores that are also available nowadays is known as TASH scores, or also known as trauma-associated severe hemorrhage scores. Okay, these scores basically there is some addition. There are some addition of laboratory measure. As we can see, there is hemoglobin, base excess, and a few other addition. There are 8 parameters that we look at this particular score, which is gender. If male gender, there's additional 1 point. And then regarding blood pressure, we look at if less than 100 mmHg, there is additional 4 point. If less than 120, additional 1 point. More or equal to 120 mmHg is 0 point. In terms of hemoglobin, if the HB level is less than 7, there is additional of 8 point, less than 9, 6 point, less than 10, there is 4 point addition, less than 11, 3 point, less than 12, 2, meanwhile more or equal to 12 is 0. And we move on to the pulse rate. For the pulse rate, we take 120 as the cut point. If it is more than 120, additional 2 point, more less or equal to 120, 0 point. Then the other part is best access. As we already have it in our recent classification of hemorrhage, here also best access is being included. This best access basically if it is less than 10, additional 4 point, less than 6, additional 3 point, less than -2 plus 1 and more or equal to -2 is 0. Okay, then any positive fast scan, additional 3 point, any unstable pelvic fracture, additional 6 point, and any open or dislocated femur fracture is additional 3 point. Okay, done with the MTP scoring, now we move on to the other part of circulation, which is damage control resuscitation. So what is damage control resuscitation? Damage control resuscitation is a systematic approach to the management of trauma patients with severe injury that start in the emergency room, continue throughout the operating room, and throughout the intensive care units there. DCR involves hemostatic resuscitation, permissive hypotension whenever appropriate, and damage control surgery. DCR aims to maintain circulating volume, control the hemorrhage, and correct the lethal triad of coagulopathy, acidosis, hypothermia until definitive intervention is appropriate. So what does we have in the damage control resuscitation? First is minimize crystalloid use during early resuscitation. As mentioned by Dr. Hafiz earlier, nowadays we only use 1 liter of crystalloid for adult. Meanwhile, in children, it's 20 ml per kg of crystalloid. Okay. Second is permissive hypotension. The idea of permissive hypertension is first to allow systolic blood pressure to fall low enough to avoid exsanguination but keep the high enough to maintain perfusion. Second, the goal is to avoid disruption of an unstable clot by higher pressure and worsening of bleeding. Third is to avoid cyclic over-resuscitation, meaning we overly resuscitate the patient, which can lead to rebleeding and paradoxically can actually exacerbate hypotension despite high amount of fluid resuscitation and may lead to subsequent complication, which is I mentioned in the later triad just now. Fourth is low BP actually is not the target. It is a compromise. It's a compromise to pending emergency surgical intervention. Fifth, basically, this is done to find the best. This is the hemorrhage control is the goal of what we are doing now, the permissive hypotension. But once this is achieved, hemostasis and surgery is in place, normalization of the hemodynamic status is appropriate. This is what I mentioned regarding the latter triad just now, the coagulopathy, hypothermia, metabolic acidosis. Okay, now we move on to what is there in damage control resuscitation. If damage control resuscitation started pre-hospitally, there is around 87 to 100% survival rate. And first is use 1 liter warm saline. Why do we use warm saline? This is to prevent hypothermia. And second, why is only 1 liter? This allowed us to prevent dilutional coagulopathy due to too much of saline infusion. And too much of saline infusion may cause acidosis, which is a part of the little triad. Second is to switch to blood product as early as possible. Okay, so the blood product should be in a ratio of 1:1:1 ratio, which is the ratio of plasma, and then the ratio of RBC, and the ratio of platelet. Finally, what is there in damage control resuscitation is to prevent or reverse coagulopathy. This is by using thromboelastography. Thromboelastography is actually an investigation that allowed us to identify particular coagulopathy problem in a patient. This is actually a study that's showing regarding the ratio of blood that should be used, which is the best ratio. First studies is a prospective observational multicenter major trauma transfusion studies, which is done in 2030. This is comparing between plasma and red blood cell 1:1 ratio and plasma red blood cell in 1:2 ratio. It is noted that ratio of less than 1:2 had 3 to 4 times increased rate of mortality than 1:1 ratio. This is only measured in the 24 hours of admission. But after 24 hours, this ratio is unassociated with mortality. Another one, newer studies, which is done in 2015, which is the pragmatic randomized optimal platelet and plasma ratio. This is comparing between plasma platelet RBC ratio of 1:1:1 and plasma platelet RBC ratio of 1:1:2. And it's noted that reduced mortality from bleeding in first 24 hours when we use the 1:1:1 ratio, as it allowed us to reduce exsanguination. However, overall mortality rate at 24 and 30 days, there is no difference. This is what I mentioned just now regarding thromboelastography. Okay. Regarding thromboelastography, this is a new update introduced in ATLS, especially to manage the patient with coagulopathy problem. Conventional coagulation tests such as the INR, APTT, PT prothrombin time does not provide an accurate representation of the complex nature of trauma-induced coagulopathy. Thromboelastography may provide you with prompt global overview of all the dynamic sequential aspect of trauma-induced coagulopathy. Okay. Another important part is regarding the use of tranexamic acid. A large prospect study demonstrates decreased mortality when tranexamic acid is used within the 3 hours of injury, when 1 gram of dose is given in the pre-hospital setting. I mean pre-hospital. Nowadays, I think even our AMO staff, those who attend patient at scene should know how to administer tranexamic acid and when it is appropriate, as it is known to cause decrease in mortality in 1 hour, less than 1 hour by relative risk of 0.68. Meanwhile, in between 1 to 3 hours, relative risk of 0.79. And there's increase of mortality if it is more than 3 hours application. So basically, what I take home message from what I've said just now, first is regarding amount of crystalloid should be minimized, which is only 1 liter of crystalloid, or in adult in pits 20 cc per kg for those who less than 40 kilo. Early blood in a ratio of 1 to 1 to 1, and then use of tranexamic acid, and finally regarding the thromboelastography whenever it is available in your center. So I would like to hand over the mic back to our host today, Dr. Hambali. Thank you for listening.
Thromboelastography. I think that's the first time I've heard about it. Maybe if we have time later, Dr. Ramlah can explain more regarding thromboelastography, maybe. Okay, thank you, Dr. Ramlah, for your presentation. Now it's time for our last panelist to talk. Let's invite Dr. Amira to talk about current update on chest injury. Silakan, Dr. Amira Iliani.
Okay. Assalamualaikum and good morning to all.
Okay.
Assalamualaikum and good morning to all. Thank you, Dr. Hambali. Okay, so next I will share an update of thoracic trauma in the latest ATLS. So the life-threatening thoracic injury can result from airway obstruction, tracheobronchial tree injuries, tension pneumothorax, open pneumothorax, massive hemothorax, cardiac tamponade, and also traumatic circulatory arrest. So as we can see in the 10th edition of ATLS, tracheobronchial tree injury is now included in the Little 6 causes of life-threatening injuries, replacing the flail chest from previous ATLS. So injury to the trachea or a major bronchus is an unusual, but it is a potentially fatal condition. So the majority of tracheobronchial tree injuries occur within 1 inch of the carina. So these injuries can be severe, and the majority of patients die at scene. So those patients who reach the hospital alive have a high mortality rate from associated injury, inadequate airway, or development of tension pneumothorax or tension pneumopericardium. So next we move on to tension pneumothorax. Tension pneumothorax develops when a one-way valve air leak occurs from the lungs or through the chest wall. Then air is forced into the pleural space with no means of escape and eventually collapsing the affected lung. And the mediastinum is displaced to the opposite side, which can decrease the venous return and also compress the opposite lung. And patients with tension pneumothorax who are spontaneously breathing come to ED, present with chest pain, air hunger, tachypnea, respiratory distress, tachycardia, hypotension, and tracheal deviated away from the site of injury, unilateral absence of breath sound, elevated hemothorax without respiratory movement, and also neck vein distension, whereas cyanosis is the late sign of tension pneumothorax. So patient with tension pneumothorax require immediate decompressions and may be managed by rapidly inserting a large over the needle catheter into the pleural space. So recent evidence support by placing the large over the needle catheter at the fifth interspace slightly anterior to the mid-axillary line. So in adult, the recommended site of needle decompression, as we can see here, in the latest ATLS is that the fifth intercostal space mid-axillary line, whereas in pediatric it's unchanged, still at second intercostal space mid-clavicular line. So the recommended size for needle decompression is 14 gauge with the length of 3.25. So there is a needle compression study on cadaver have shown improved success in reaching the thoracic cavity when the fifth intercostal space mid-axillary line is used instead of second intercostal space mid-clavicular line. So it's shown if we use the fifth intercostal space in the study shown in fifth intercostal space, there is 100% success as compared to the second intercostal space mid-clavicular line. So the focus abdominal sonography for trauma or FAST scan has been modified to include evaluation of the thoracic cavity for the presence of air. So it can aid the rapid diagnosis of pneumothorax in emergency department. So when ultrasound is available, tension pneumothorax can be diagnosed using the extended FAST by looking for seashore, barcode, and also stratosphere sign. So seashore sign is we can see in normal lungs, while the barcode or stratosphere sign we can see in pneumothorax patients, patient with pneumothorax. Okay, so extended FAST has been used to detect both pneumothorax and also hemothorax. However, other potentially life-threatening injuries are not well visualized by using ultrasound. So we need chest X-ray to evaluate further injury in patient with post-trauma injury. So as we can see here, extended FAST is include the four common window that we always use: subxiphoid, right upper quadrant, left upper quadrant, and also pelvic window, with addition of right thorax and left thorax to rule out pneumothorax and also hemothorax in trauma patients. And there is evidence-based review that suggests that bedside thoracic ultrasound is more sensitive screening for than chest X-ray to diagnose pneumothorax. So the sensitivity of ultrasound in detection of pneumothorax is ranged from 86 to 98% with specificity of 98 to 100%, while chest X-rays sensitivity is only 28 to 75%, and the specificity is 100%. So that's all from me regarding the ATLS update in thoracic trauma. So I pass back to our host, Dr. Hambali.
Thank you, Dr. Amira, for brief explanation regarding current update on chest injury. So, my fellow colleagues and all the attendees, bear in our mind during handling trauma case, atom TC is a new mnemonic, and atom FC is no longer being used. So, thank you again, Dr. Amira. I think we had banyak masa lagi. Mungkin Dr. Hafiz boleh tambah apa-apa yang patut regarding airway ke chest injury maybe. Dr. Hafiz? Dr. Hafiz, ada benda nak tambah?
What Dr. Ilya has mentioned, it is also stated.
Maaf Dr. Hafiz. Dr. Hafiz, tak berapa clear Dr. Hafiz. Mungkin Dr. Hafiz boleh adjust mic ataupun buka mask.
Hello?
Okay. Good, good.
Right,
Loud
okay.
and clear. Okay. Silakan Dr. Hafiz. Minta maaf Dr. Hafiz sekejap. Untuk soalan Dr. Aida, sekejap Dr. Aida, kita akan ada Q&A session at the end of the session. So maybe we can hold them to at the end of session. Okay, we give chance to Dr. Hafiz to sit first. Thank you Dr. Aida.
Okay, thank you again, Dr. Hambali. All right. Okay. Apart from what Dr. Ilyani has mentioned, for the treatment of tension pneumothorax, it is also emphasized in this current ATLS that the finger decompression is emphasized of its usefulness. Finger decompression is a potential treatment after the needle decompression prior to the insertion of chest tube insertion. So this figure is actually was demonstrated in this ATLS book. As we can see in this picture, a surgeon is putting his finger through the needle site, surgical site for insertion of pneumothorax. So by putting the finger, it can slowly release the tension pneumothorax. Sorry. Alright. However, the needle and finger decompression is not is only just for a temporary measures. It is a mandatory afterward that we have to follow with the chest tube drainage or chest thoracostomy. Another indication of chest tube incision is massive hemothorax. Massive hemothorax is defined as an initial blood loss of more than 1.5 liter or continuing blood loss of more than 200 cc for the next 2 to 4 hours. For the treatment of massive hemothorax, we have to concurrently decompressing the chest cavity via the chest tube drainage, as well as simultaneously we have to restore the blood volume loss. Okay, in this current ATLS updates, the ATLS recommend that the use of chest tube is reducing in size to 28 to 32 French of chest tube. Of chest tube instead of the previously 36 to 40 French. So does the size of chest tube matter to us? Okay, there's a prospective analysis done by Dr. Kenji Inaba in 2012 that mentioned from this study is actually evidence based to give a proper treatment and the size of the chest tube. In this prospective analysis, the uses of chest tube of size 28 to 32 French versus 36 to 40 French. In this study that mentioned, there is no increase in the rate of complication regarding the chest incision in terms of the retained hemothorax following the chest tube. Furthermore, there's also no significant difference with the use of smaller versus the larger size tube. So it's about the same. So it's better we use the smaller size. Okay. There's a possibility that patient come in with massive hemothorax that having ongoing bleeding. Who's not responding with our chest tube drainage. Is generally indicated for open thoracotomy. As you can see in this picture, this is the picture of anterolateral thoracotomy. Thoracotomy is different from thoracostomy. Thoracostomy, chest tube drainage. Thoracotomy is we open the thorax. Okay, from this table, we can see this is actually the indication of open thoracotomy. In adult, the immediate output of blood coming out from the chest tube of more 1.5 liter in the first hour, or ongoing output of more than 200 cc per hour over the next 2 to 4 hours. Or in children, the immediate output of more than 20 ml per kg in the first hour, or ongoing output of more than 3 ml per kg per hour over the next 2 to 4 hours. Okay, if you guys realize, actually this is the definition of massive hemothorax. So if the patient is having hemothorax, is actually one of the indication to open to thoracotomy. But do not perform thoracotomy unless a surgeon qualified by training and experience is present. Okay, in this current latest edition, 10th edition book, also there's a new traumatic circulatory arrest algorithm. All the trauma patient presented with unconscious, having asystole, ventricular fibrillation, they are treated. Usually, this patient having a severe, usually happen because of circulatory problem. Okay, the causes of the traumatic circulatory arrest can be due to severe hypoxia, severe hypotension, profound hypovolemia, or severe myocardial contusion. Don't worry if you cannot see this algorithm clearly, because I will explain on the next slide. Okay, this is the summary of traumatic circulatory arrest algorithm, the previous algorithm. Okay. When the patient, traumatic patient brought to us in unconscious state, we have to do the immediate CPR, secure the airway with orotracheal intubation without using the RSI, especially is unconscious. Put a IV drip, it's either through IV or IO, administration of epinephrine. If tachyarrhythmia is present, ventriculation, ventricular fibrillation, we just follow the ATLS algorithm. At this point of time, we have to alert our colleague surgeon to get standby in the operating room. Okay, if the patient after the initial resuscitation, CPR, epinephrine, patient attain ROSC. So we follow to the usual management. We started the concurrent primary survey, secondary survey, and then post resuscitation care and the definitive treatment of the injury. Okay. But if the patient do not attain ROSC, we have to proceed with needle or finger chest bilateral chest decompression and proceed with chest tube drainage. Okay. If patient attain ROSC after the chest tube, follow the usual management. Okay, but if there's a patient still do not attain ROSC, in the setting of patient in the setting of hospital that we have experienced surgeon, we can proceed with anterolateral or clamshell thoracotomy with vertical pericardiotomy. Okay, then the next step is done by the surgeon in the OT. If there is a thoracic injury, we do direct repair. If there is abdominal injury, we do clamp aorta. And death is usually pronounced after the 30 minutes of full resuscitation. If in our hospital doesn't have available surgeon, then our effort may be up to the chest tube decompression. If there's pericardial effusion, we just do pericardiocentesis, and then resuscitate with volume and blood products. Okay. Well, I think that's all from me. All right. Thank you.
Thank you, Dr. Hafiz. So that's the current update for uh, traumatic circulatory arrest in ATLS 10 edition. So do not perform thoracotomy unless a surgeon qualified by training and experience is available in your hospital setting. So this is quote from Dr. Hafiz. Thank you so much for your brilliant presentation. I think we have untuk all the attendees and semua attendees, if there's any question, we will you can ask through the Q&A box or through the chat one, And we will answer that question at the end of our session, because we had a Q&A session at the end of our webinar. Thank you. So without further ado, I will pass this mic to Dr. Ramlah, because there's some more to talk about circulation update in ATLS 10 edition. Please, Dr. Ramlah.
Now we continue with the second round. Basically, what I'm going to talk about in this particular slide is regarding traumatic aortic rupture, which is a common cause of sudden death after a vehicle collision or fall from great height. Survivor of this injury frequently recover if aortic rupture is promptly identified and treated expeditiously. The presentation and treatment of blunt traumatic injury has evolved with the use of CTA, which is a thoracic computerized tomography angiography, also known as CTA. This is to evaluate for blunt aortic injury. Hemodynamically normal patient with partial injury are now managed with endovascular technique. The injury is medically managed by decreasing the heart rate, which means the heart rate less than 80 beats per minute, and for the mean arterial pressure to be in between 60 to 70 mmHg by using beta blocker. So the beta blocker or drug of choice, if there is no contraindication, we usually use IV esmolol. For those with hemodynamically stable patient, it is possible for us to go for endovascular repair. And now we move on to the update under burn injury. There is a new change in fluid resuscitation for burn injury. Modern burn resuscitation has mirrored the changes in trauma fluid resuscitation. Adult patient with deep partial and full thickness, deep partial and full thickness burn involving more than 20% of the total body surface area should receive initial fluid resuscitation of 2 ml of finger lactate multiplied with the percentage, the kilogram, the body surface area for age more than 14 years old. Meanwhile, for children, they need 3 ml ringer lactate multiplied by a kilogram and the percentage of total body surface area if it is less than 14 years old. For those who are less than 30 kilo, dextrose containing solution should be added in the maintenance. Meanwhile, for this electrical injury, we actually use 4 ml ringer lactate multiplied by the kilogram and the percentage of total body surface area for all ages. Okay, half of the fluid is given over the course of 8 hours and remaining half is provided over a span of 16 hours. Okay, so basically if we give fluid, so surely what we need to do is the strict input and output chart. The target urine output for this patient, especially children, is around 0.5 ml per kg per hour, and for adult, 0.5 ml per kg per hour. Meanwhile, in children, is around 1 ml per kg per hour for a hemodynamically normal. Meanwhile, for those who are hemodynamically unstable, boilers are reserved for them. So that's all from me. Back to Dr. Hambali.
Okay, thank you, Dr. Ramlah. Thank you, Dr. Ramlah, for little update for that fluid resuscitation. Dr. Amira, is there anything you want to add as we are nearing at the end of our webinar?
Okay, I have a few things to
Okay, Dr.
share.
Amira. Okay, thank you.
Okay.
Wait a minute. Chip, we will answer that question at the end of our session. Thank you for the question. Thank you. Okay, Dr. Amira.
Okay, thank you to our dedicated host, the Hambali. So next I will talk about head trauma update in ATLS. So first, a little bit regarding statistic of head trauma. So head injuries are among the most common types of trauma encountered in emergency department, and many patients with severe brain injuries die before reaching hospitals. So in fact, nearly 90% of pre-hospital trauma is related trauma-related death is involving brain injury. And among the patients with brain injury who receive medical attention, approximately 75% of patients with brain injuries is having mild injuries, and 50% is moderate, and 10% is severe. So the primary goals of treatment for patients with suspected traumatic brain injury is to prevent the secondary brain injury. So the most important ways to limit secondary brain damage is um, to ensure adequate oxygenation and maintain blood pressure at a level that is sufficient to perfuse the brain, and it will improve the patient's outcome. So the Glasgow Coma Scale, or we know it as GCS, is there's a new GCS introduced in the 10th edition. So this version of GCS stresses reporting the numerical components of the score, and they add new designation, which is NT, or not testable. So it is to be used when a component of the score cannot be assessed. For example, in patients with amputated limbs. So the GCS scoring, as we can see here, 13 to 15 is mild, 9 to 12 is moderate, and 3 to 8 is severe. So the fourth edition of the Brain Trauma Foundation's guideline for the management of the severe traumatic brain injuries that are applicable to the early management of brain injured patient have been included in this new latest edition of ATLS. So this guideline include avoiding prolonged hyperventilation with PCO2 of ABG less than 25 millimeter mercury, and to maintain systolic blood pressure more than 100 millimeter mercury for patient aged 50 to 69 years old, and systolic pressure more than 110 millimeter mercury or higher for patient aged 15 to 49, or patient that are older than 70 years old. And for sedation, propofol is recommended for the control of increased intracranial pressure, but not for improvement of 6-month outcomes of the patients. And for seizure prophylaxis, phenytoin is recommended to decrease the incidence of early post-traumatic seizures within 7 days of injury. And the prophylactic use of phenytoin or valproate is not recommended for preventing late post-traumatic seizures. So this is the goals of treatment of brain injury that includes clinical parameters, monitoring parameters, and surveillance parameters. So for clinical parameters, as I said before, to keep systolic BP more than 100 millimeter mercury with temperature to maintain between 36 to 38 degrees Celsius. So for monitoring parameters, usually in ICU setting, we need to keep the CPP, or cerebral perfusion pressure, more than 60 millimeter mercury, with ICP ranging in between 5 to 15 millimeter mercury, and oxygenation more than 95. And for lab parameters, glucose in normal range to keep between 8 to 18 millimole, hemoglobin more than 7, INR 1.4 or less than 1.4, and normal sodium range 135 to 145, PaO2 of ABG more than 100, PaCO2 within normal range also 35 to 745, pH 7.35 to 7.45, and we need to keep platelet more than 75. So for anesthetic, sedation, and analgesic agents should be used cautiously in patients who have suspected or confirmed brain injury. So overuse of these agents can cause a delay in recognizing the progression of serious brain injury, impaired respiration, and it will result in unnecessary treatment such as endotracheal ventilation. So instead, it is recommended to use short-acting, easily reversible agents at lowest dose, just for pain relief and for mild sedations. So Low dose of IV narcotics may be given for analgesic, and it can be reversed with naloxone if needed. And for short-acting, and also short-acting IV benzodiazepine such as midazolam can be used for sedation and can be reversed with flumazenil. So head injury on anticoagulation. So a study was done and recommended that all patients on warfarin should have INR performed at ED, and the CT scan should be done in most patients that are on anticoagulation medication. So all supratherapeutical anticoagulated patient or patient with deranged INR, as well as patient on anticoagulation with traumatic CT abnormality, should be admitted for neurologic observation and KIV for short-term reversal of anticoagulation. And routine repeat of CT scan is strongly recommended at 12 to 18 hours or when there is subtle sign of neurologic worsening in on patients. So regarding the anticoagulant reversal guidance, we can find this table in ATLS, page 121. So as we can see here, patient with antiplatelet or on aspirin or Plavix, we can give platelet to reverse the anticoagulant effect, and also can consider the DDAVP, which is a deamino delta dearginine vasopressin. And patient on warfarin, we can consider to give FFP, vitamin K, prothrombin complex concentrate or PCC or factor 7A to reverse the anticoagulant effect. And patient on heparin and enoxaparin, we can give prothrombin sulfate. And patient on Pradaxa, we can give Praxvine or PCC. So in traumatic brain injury cases, CT scan is the preferred method of imaging. Although obtaining CT scan should not delay the transfer of the patient who requires the treatment to the tertiary hospital. So we need to request CT scan in all patients with suspected brain injury who have clinically suspected open skull fracture, any sign of basilar skull fracture, and more than patient with more than 2 episodes of vomiting. And we need also to request CT scan on patients who are older than 65 years old. So PECARN or Pediatric Emergency Care Applied Research Network criteria for head CT suggested algorithm A to use in less than 2 years old, and algorithm B to use in patient with age more than 2 years old who score GCS 14 to 15 after head trauma. So as we can see here, in algorithm A, patient with GCS 14 or other sign of altered mental status or with palpable skull fracture, the CT is recommended if patient had no sign of I mentioned before. So we need to further monitor, further evaluate whether the patient had occipital, parietal, or temporal scar hematoma, which is except the frontal hematoma, or history of LOC more than 5 seconds, or severe mechanism of injury and not acting normally as per parents. So might consider CT scan. And we need to see other clinical factors such as first the physical experience, multiple versus isolated findings, worsening symptoms or sign after emergency department observation. Usually we keep 6 hours at ED for observation, or in some hospital admitted to neurological ward for observation, and patient with age less than 3 months old. With and also last but not least, if parents is preferred for CT scan. And if patient had no sign and symptoms of this, CT is not recommended, and we can just observe the patient. So in algorithm B, same GCS 14 with other sign of altered mental status or signs of basilar skull fracture in patient more than 2 years old and above. So CT is recommended in this patient. So if patient had history of loss of consciousness, history of vomiting, or severe mechanism of injury, or severe headache, observation is recommended, but KIV for CT scan due to same reason as above So this is the summary of the PECARN algorithm. So if the examination is abnormal, get the CT scan. So if LOC lasts more than 5 seconds, hematoma anywhere, anywhere but frontal, and also with severe headache, vomiting, severe mechanism to rule out cervical spine fracture, and also parental GCS less than 15, we can continue observation at ED, KIV for CT brain. If patient had no of all of the symptoms, just monitor the patient and we can discharge patient with the head injury advice. So that's all from me. Hope you gain some input from highlight of ATLS update from my presentation. So we get back to our host, Dr. Hambali.
Okay, thank you, Dr. Amira. Thank you, Dr. Amira, for talk about head injury update. Okay, I think that's all from our panelists today. So tiba masa untuk Q&A session. Sebab masa dah tak ada, tak berapa banyak. Dah pukul 10 and already 1 hours of this webinar. So ada dua soalan satu daripada Dr. our specialist Dr. Aida Nusharini. This question is specifically directed to Dr. Amira Ilani lah. So to Dr. Amira Ilani, what does specificity of 100% in IFAS for pneumothorax mean? Okay, Dr. Amira, boleh jawab?
Okay, regarding question by Dr. Aida, so high specificity in extended fast. So high specificity means it can rule in disease. It is high true negative rate. So it is useful when the result is positive. So in extended fast, 98% to 100% specificity, it means that it can rule in that it can sorry 98 to 100% specificity of extended fast. It means it is it already ruled out the true negative, which is included so it is high specificity first is high true negative rate. So maksudnya kalau patient kita buat extended fast, so we found there is pneumothorax. So it is memang true pneumothorax pneumothorax lah in that patient. So it already ruled out the false positive finding in the patient. So the acronym of high specificity is high specificity ruled in. So investigation with high specificity can rule in the diagnosis. It can diagnose the pneumothorax lah. So if high sensitivity, it can rule out the findings lah. Maksudnya kalau kata there is negative finding of pneumothorax in patient, so if fast is also high in sensitivity, it can rule out already that patient have no pneumothorax. So
okay, thank you Dr. Amira Ilani. Hopefully Dr. Aida get the answer. Okay, there's one more question from our chief. From our chief Muhammad Zulkifli. For needle decompress, our PhD team can do outside hospital, and if can, our PhD team need consult with MO or EP first before procedure. I think this question Dr. Hafiz boleh jawab. Our panelist Dr. Hafiz boleh jawab tak agak-agak Dr. Hafiz?
Okay, Bismillahirrahmanirrahim. Sorry. Okay. Assalamualaikum. I'm sorry. Currently I'm outside, so I have to wear mask at this public area.
Sekejap
Sorry.
Dr. Hafiz, sekejap Dr. Hafiz. Dr. Aida, okay, Dr. Aida nak cakap sekejap. Kita bagi chance untuk Dr. Aida untuk cakap sekejap. Okay, Dr. Aida. Boleh cakap sekarang, Dr. Aida?
Okay. Sorry, yang jawapan tu salah tadi. Iliani, that's not correct. You were correct, you were initially wrong, and then you were right, and then you were wrong again, and then it's all gone haywire. You just have to explain simple terms. What is it when you do EFAST for pneumothorax and it says 100% specificity? What does it mean? Simple terms. The other panelists, boleh bantu tak?
All our panelists, clear tak ada soalan Dr. Aida tu? Boleh dengar?
Ataupun Hambali lah jawab.
uh,
High specificity can rule in disease. High sensitivity can rule out disease.
No. No. Azmira, you tulis apa tu? You answer. But explain it in IFAS punya maksud lah. Saya tanya, IFAS tu 100% spesifik untuk pneumothorax maksudnya apa?
Okay.
Adik Azmira jawab. Okay, the answer is correct. But how is it related to pneumothorax ni? Specificity is the ability of a test to detect those without the disease. So what does it mean in IFAS?
In specificity 100%, that means if we do EFAS, if there's we couldn't find any evidence to suggest pneumothorax, then there's no pneumothorax.
Which evidence?
If specific 100%, sorry.
Which evidence?
Which evidence?
What sign?
From there's no if the sliding sign is present, then this patient have no pneumothorax.
Kalau sliding sign nampak je, confirm tak ada pneumothorax. That's what it means. That was my question. Saya bukan tanya apa maksud specificity tu. Itu kan dah bincang dalam group. I want to know, you all faham tak? What does specificity 100% for pneumothorax EFAS? That means EFAS to rule out pneumothorax is better than chest X-ray. 100% specificity. You nampak je sliding sign, confirm tak ada pneumothorax. Confirm. 100% no pneumothorax. That's what it means. 100% specificity maknanya it rules out. Okay? Jangan nak go high-fi low false positive ke, low negative ke, when the real meaning pun you tak faham. Understand? Meaning, kalau you tengok patient and you want to rule out pneumothorax, tak payah tunggu chest X-ray.
Betul.
Belajar buat EFAS.
Sas.
Itu maksudnya. When you present something, we want to apply it day to day. Okay?
Okay, Dr. Aida. Terima
Ini
kasih.
semua pusing. I already said, simple terms. What does it mean? Okay? So lepas ni, kalau you tak sure patient ada pneumothorax ke tidak, buat EFAS sahaja. Because that is more specific than chest X-ray.
Okay, Dr. Aida. Terima kasih, Dr. Aida. Terima kasih.
Somebody, can you repeat Sid punya question? Because I don't see it anywhere.
Okay. I will repeat that question.
Jangan bagi laju-laju because I don't see it anywhere.
Okay, thank you, Dr.
This
Aida.
webinar is not very attendance friendly.
Okay.
Yelah, aku tak boleh nak tanya soalan. Bye. You can mute me now.
Okay, thank you, Dr. Aida. Thank you for our EP for that question. Hope kita dapat input lah. Alright, so soalan daripada Chip. For needle decompress, our PHC team can do outside hospital? Soalan. And if can, our PHC team need consult with MO or EP first before procedure. Dr. Hafiz, jawab kot.
Okay, Bismillahirrahmanirrahim. I will answer the question, but before that, I'm sorry because I'm outside, so there's maybe additional or extra noise. Okay, for the question, cheap question. Sorry. Okay, Actually, okay, for the needle decompression, okay, our PSC team can do outside hospital. Yes, I believe our PSC members that attend the PSC case already equipped with the TLS. So if you manage to find tension pneumothorax at signs, patient with having probable chest injury, you suspect patient having tension pneumothorax, you able to diagnose it on scene. You have to do it immediately because it's life-saving procedures. But if there's no need to put a chest tube drainage, if as it may cause a delay in transfer the patient, we have to weigh the benefit and disadvantage. But you have to correlate with us as well what the injury with the center lah. You going outside, you tell us at the center what's the patient's having suspected injury, what you have done, and then at the same time we can prepare. So we already know the patient on scene having chest pneumothorax. You already do chest or needle decompression, and if patient improving or not, you send in. We already prepared what the team should prepare. And when you're telling us this, I believe if you want to cost up first, is also no problem. But if you're confident to do it, I think you can do it. All right. If this answer is query, or maybe Dr. Aida have some input, maybe you can add in. All right.
Okay, Dr. Aida boleh tambah, Dr. Hafiz.
Okay, that is absolutely correct. A needle decompression for tension pneumothorax is a life-threatening injury. So chip, siapa-siapa yang first responder mesti ada training in ATLS or MTLS lah. Okay, so of course when you treat patient, the first thing is to do no harm. Right? If you do not know how to do it, do not do it. Okay, alright. So having said that, orang yang tahu buat hanya boleh responsive lah. Alright, ni maksudnya semua kena tahu macam mana nak buat. Okay, not just MA, not just MO lah, MA semua kena tahu buat. That's why those yang first responders yang naik ambulance tu, you must know lah. You mesti tahu ACLS dan you mesti tahu ATLS. Kalau boleh tahu pediatric lah support, also kena tahu juga. Okay, right? Sebab sepatutnya any life-threatening injuries, you should be able to give the first treatment. So it's either a stay or play or scoop and run. Tapi in terms of life-threatening injuries, you must at least attempt. Right?
Okay, Dr.
So
Aida.
Cik, make sure you punya team semua ada ATLS, ACLS.
Okay.
Bukan paramedik je ya, MO semua. Tak kira lah MO tu nak buat pathology ke, tak nak buat ED ke, nak buat ENT ke, whatever not. Sekarang ni you all MOED ya, you all naik ambulance kan. Kalau ada case you all naik kan, so you all kena tahu.
Betul, Dr. Aida.
Okay, bolehlah mute saya semula. Bye.
Okay, kita ada baki lagi dalam 2 minit lah. Mungkin Dr. Syafwan nak cakap apa-apa regarding this webinar ataupun tak ada? Dr. Syafwan, WSOD. Dr. Syafwan ada tak? Tak ada ya? Okay. Okay. So let's wrap lah this our webinar. To conclude that ATLS 10th edition offer new insight into managing trauma patient. So this ATLS Global Education Curriculum provide a systematic, concise approach to trauma patient care in an effort to improve trauma outcome around the world. The content and skill taught in the course are designed to be adaptable to all healthcare settings for the care of patient and are intended for the immediate management of the injured patient. The knowledge gained through the course allow participants to rapidly and accurately assess the patient, stabilize and resuscitate by priority, determine the needs of the patient and whether those needs exceed the resource of the treatment facility, or arrange for appropriate definitive care and ensure that optimal care is provided. So for our MOs and paramedics, maybe ada duit lebih boleh masuk ATLS course. That's all from me, and thank you to all our panelists and Dr. Shafwan and Dr. Aida for supervise our webinar. Jumpa lagi minggu depan di waktu dan hari yang sama, tetapi panelis dan host yang lain lah. Yang buruk itu datang daripada kami, yang baik itu datang daripada Allah. Mari kita tutup dengan tasbih kifarah dan as. Okay, thank you. Assalamualaikum warahmatullahi
Okay, terima kasih semua.
wabarakatuh. Bye.